Now call upon Professor Paolo and SILVA talking about the ultra-wide field imaging for diabetic retinopathy. Remember the days when we had a 30-degree camera and ETDRS talked about the 7 field where the disc center, macula center, up and down sides-wise. Then it moved from to 45-degree or 60-degree. Today it has got ultra-wide field. While most low resource countries cannot manage it, cannot procure it, but then they're not denying that this is useful for certain situations, if not all.
So,
Dr. Silva.
So good morning. So it's a pleasure to be here and to be able to share some of our work highlighting how ultra-wide field imaging is changing how we diagnose diabetic retinal disease. So these are my financial disclosures. So telemedicine programs for diabetic retinal disease rely on remotely acquired images, a centralized evaluation of these images, and findings communicated to the remote site. Data from the UK has shown that with current diabetes and eye treatments combined with telemedicine, this may reduce the incidence of diabetes blindness by as much as 95%. So ungradable images impact telemedicine programs. Ungradable images can vary from 10 to up to 56%. So it's critical to identify methods to decrease ungradable images. Ultra-wide field imaging has decreased the ungradable rate from 10 to less than 3% per patient in our program in Boston. It also identified twofold more patients with DR and referable DR without the need to dilate pupils. Potentially, a combined ultra-wide field and OCT imaging device is an ideal system for many diabetic retinopathy screening programs. It allows the imaging to be acquired in the same sitting, improving patient and healthcare logistics, particularly in eyes with visually threatening center-involved macular edema, as the OCT integration increased the detection of true cases of CIDME by over 7-fold and reduced the rate of false negative cases by over 66%. So the current diabetic retinopathy severity scales are designed to predict progression to PDR. However, estimates are broad and each severity level may not represent a group with similar long-term risk. So we have described what's termed as predominantly peripheral lesions that may be present in up to 50% of eyes. This increases DR severity in about 9 to 15% of eyes and can be identified with ultra-wide field color or FA imaging. This data, along with data of others, has supported the development and performance of Protocol AA. So DRCR Protocol AA was a prospective longitudinal study to understand whether ultra-wide field imaging improves our ability to evaluate diabetic retinopathy and predict progression. So this is an eye wherein the areas with PPL are highlighted by the white arrowheads. Focusing on the superior temporal quadrant, you can see these lesions occur outside the ETDRS fields. With the ultra-wide field FA overlay, you can see these lesions occur at the boundary of the perfused and non-perfused retina. So the primary outcome of Protocol AA was the proportion of eyes experiencing DRSS worsening by 2 or more steps from baseline or receipt of treatment through 4 years. It's important to emphasize that the outcomes were assessed within the ETDRS fields using ultra-wide field images. So this graph shows disease worsening in PPL, showing no difference in the rates of progression. However, when looking at eyes with more severe DR levels, the presence of PPL on color was associated with a higher risk for progression. This graph shows DR worsening and FA identified on FA, PPL identified on FA. And you can see when PPL by FA was present, the risk for DR progression was much higher. And this was consistent across all DR severity subgroups. So in the AA cohort, eyes with PPL by FA had a 1.7-fold greater risk of disease worsening over 4 years. This was consistently present across all DR severity subgroups. Among eyes with NPDR, the presence of PPL identified using ultra-wide field FA imaging appears to be a marker for increased risk for disease worsening that is not detectable using standard ETDRS photography or ultra-wide field color imaging alone. So fluorescein angiography of the ETDRS area has been studied in detail. However, only 2 30-degree FA fields were evaluated in the ETDRS. Data from Protocol AA has shown that with increasing DR severity, you see increasing retinal non-perfusion. However, baseline presence of PPL on color was not associated significantly with increased non-perfusion. However, PPL on FA was significantly associated with a 50% increase in retinal non-perfusion. Similarly, eyes with the highest non-perfusion were at the highest risk for developing progression over 4 years. So worse DR severity was associated with the increasing non-perfusion. Non-perfusion identified on the ultra-wide field FA in these diabetic eyes was located primarily in the mid and far parietal periphery that are not visualized by standard ETDRS FA imaging. And the presence of PPL identified on FA has been shown to be increasing, associated with increasing retinal non-perfusion. We also evaluated the effect of DR lesion location and severity. So these series of graphs show disease worsening by lesion severity location. So you can see in both ultra-wide field color and FA, irregardless of the lesion location, the risk for retinopathy worsening was similar. DR lesions identified on ultra-wide field color and FA images, whether predominantly within, predominantly outside, or uniformly distributed, have similar risks for DR worsening. So we also looked at whether these peripheral lesions, which increase the severity level, predict long-term progression. So this is an eye with mild NPDR on the masked ultra-wide field color image. You can see HMAs less than 2A, but on the unmasked ultra-wide field FA, you can see significantly more lesions, and with HMAs greater than 2A and ERMAs greater than 8A out in the retinal periphery. So these series of slides showed disease worsening by the presence of more severe lesions in the periphery. And when these lesions in the periphery are present, the risk for DR worsening is increased. So this suggests that failing to identify eyes that only have posterior lesions will lead to an underestimation of risk of DR worsening, and that identification of lesions throughout the entire retina is critically important to accurately stratify the risk of progression over time. So we also looked at the agreement between what we see on the FA and the color in the assessment of DRSS. As I mentioned earlier, with these more peripheral lesions when present on the FA, the risk for worsening is increased. So this is a cross-tabulation of the unmasked ultra-wide field DR severity and the masked ultra-wide field color. And you can see 62% more severe DR on the unmasked ultra-wide field images, suggesting that you really see much more disease. This is even more striking when you're looking at mild to moderate NPDR, with 80% more severe DR on the angiogram. This suggests that the ultra-wide field FA is more sensitive in detecting early microvascular changes and peripheral lesions that may be overlooked on the ultra-wide field color. So what does that mean? How does this impact our care? So this graph shows disease worsening by the difference in baseline DRSS on ultra-wide field FA and color. So you can see when the eye had more severe DR on the ultra-wide field image, ultra-wide field FA image, the risk for worsening is much higher. So compared to ultra-wide field color, ultra-wide field FA identifies more disease in over 50% of images. This is most evident in early levels of retinopathy. Eyes with worse baseline DR lesions on FA compared to color images had higher rates of disease worsening over 4 years. And eyes with worse baseline DRSS on the ultra-wide field FA compared to color images had higher rates of disease worsening over 4 years. So to conclude, these results suggest that features on the ultra-wide field color and ultra-wide field FA images may provide additional prognostic value in determining the risk for DRSS worsening. The accurate classification of overall disease severity and quantification of risk of disease progression could be improved by accounting for lesions to include those predominantly outside the ETDRS fields. So thank you. Before I end, I'd like to invite everyone later this year to the APVRS in Manila, in the Philippines.